Good morning. My name is Mark Ebbens. I'm a senior partner of GE Healthcare Finnemore, and I'll now share with you an overview of the innovative and highly effective approach we've applied to acute emergency care pathway optimisation in the NHS. I'll do this by describing the programme we delivered with Barking, Havering and Redbridge Hospitals NHS Trust in 2014-15. GE Healthcare Finnemore is the consulting arm of GE Healthcare. We're the largest dedicated health and social care consultancy in the UK and operate in Europe, the US, Canada, the Middle East, Australia, India and South America. Our particular strength in this case was the way we combined proven operational excellence methods with analytical modelling techniques and hands-on change management to drive real improvement, hand in hand with the staff in the trust. When we were first approached for support in early 2014, BHRUT was in the lower quartile for ED performance nationally, and the trust was in special measures. It was a tough time for all concerned, and the pressure to improve was significant. The trust engaged our team initially to help with some detailed modelling and validation of their plans to reconfigure their ED department at Queen's Hospital, their main acute site. Our initial findings, however, showed that before investing in significant reconfiguration work, the emergency flow and capacity management within the trust required significant improvement to provide a solid foundation for increased demand. I'll take you through this improvement journey, the findings, the interventions, some of the key success factors that we've identified which will help other organisations consider their approach to large programmes of transformation. Over the course of a 10-month programme, the objectives evolved and morphed as we learnt more about the underlying root causes of poor ED performance and poor patient flow. We started by validating current reconfiguration plans and demand projections for the trust, but our findings quickly led to a pause in the reconfiguration, while we planned how the main site, the Queen's Hospital, could better cope with current demand. This in turn led to a major patient flow improvement effort in the trust, culminating in us supporting operational and system resilience group efforts across the whole patch. Despite the high degree of regulatory scrutiny the trusts were under during this time of recovery, elevating the problem and the solution to a system level, not just a hospital level, helped to bring a broader perspective of how to solve things sustainably. It was not just a hospital problem. So where do we start? Initially, we carried out some detailed analysis of the demand projections and how patients might behave or migrate if emergency services were reconfigured in the area. Our analysis showed that the original projections weren't robust and that a £50 million plan for reconfiguring the ED might not be wholly justified. This led to a pause in the plans for reconfiguration and a focus on optimising the emergency flow through the current system. With that in mind, it was time for our expert team to take a close look at what was really happening in ED. Now, before making any assumptions or conclusions regarding a process, it's important to put yourselves in the shoes of the customer, or in this case, the patient. Our team spent 2 weeks camped out in the ED corridors, value stream mapping, observing and capturing the input and commentary of staff, patients, volunteers and family members. And this served two purposes. Primarily, it gave us a detailed understanding of the current state value streams for the patients, but it also established a really deep level of engagement with staff early on in the programme. We built rapport and credibility, which are vital when setting up for success. We also walked in the shoes of the staff, working with them to build a picture of how it feels when the ED is operating at high performance, greater than 90%. Versus what it feels like on a really bad day. This was quite sobering. It showed just how pressurised the staff felt and how at times they believed that the quality of patient care might be compromised. Even when they had a good day, through blood, sweat and tears and heroics, they were expected to repeat that every day. If you can hit 90% today, why can't you do it every day? That comment in itself underlined the need for staff to better understand what's behind the performance number. What's the data really telling us? And what are the drivers of ED performance? So there was a steep hill to climb, a system at breaking point, a trust under intense scrutiny and pressure, a deficit in clinical staffing, a tired and demoralised workforce, and a leadership team in flux. These really were tough times indeed. To their credit, the staff were still hungry for change. They wanted to improve, and they were willing to help. They just needed help. Patient flow across an acute system, even a single hospital, is incredibly complex. This is the actual wiring diagram, as we call it, of the Queen's Hospital at BHRUT. You can see the interconnectedness, the complexity, the boundary points, as I call them, where patients often get stuck between care settings. If demand outstrips capacity, you will see a queue, even in the simplest of systems. If you overlay variation in demand and the day-to-day, week-to-week, season-to-season dynamic, then you have a situation which is highly prone to congestion, unless it's very carefully designed, managed and maintained. Producing this wiring diagram is part of the rigour of characterising the current state. If you can't draw this diagram and populate it with real data, then you can't properly describe the system you are trying to improve. Once we'd characterised the current state, it was time to focus on root causes. To do this, we built a focused problem definition tree. Others might call this a driver diagram. We start by describing the overall goal of the system. What are we trying to achieve? To deliver safe, efficient, non-elective care, as measured by outcomes, experience, and performance KPIs. One layer down from this, we see the main drivers which affect the ability to deliver safe, efficient, non-elective care. At this highest level, we placed our focus on the cause of excessive delays or congestion in patient flow, as this was the main thrust of our effort. But we didn't ignore or overlook the impact that inefficiency, such as waste, congestion, utilisation, or clinical variation, was having on the whole system. We drilled down further through a process of expert observations, stakeholder interviews, data analysis, and we were able to prioritise the improvement efforts and align work streams to these areas. It's no surprise that adult majors admitted out of hours were top of the pops in terms of the driver of ED breaches in the system. But by monitoring and analysing the performance data daily, we began to identify patterns, dependencies, and root causes that weren't quite so obvious. As we began the process of staff engagement and the hands-on process observations and value stream analysis, we launched a parallel activity of simulating the hospital. We use our sophisticated modelling and simulation suite that we call Hospital of the Future to build a living simulation model of the hospital. It replicates with incredible accuracy the real-life behaviour of the system. Why is this useful? Because by modelling the current state, we're able to continually test what-if scenarios and improvement ideas throughout the programme. For example, we were able to accurately size the ED and all of its subunits to demand, and not just the average demand, but to the true demand and all of its variation. Modelling and simulation techniques provide the sat-nav for the change journey. They allow you to plan your route, optimise it for traffic, and make adjustments as you go. It laser guides the improvement efforts and allows you to test interventions without risk before investing in the change effort. So with this in mind, it was then time to roll our sleeves up and start the process of change and improvement. Combining the simulation and modelling outputs and the clinical and operational change expertise in our team, plus close engagement, really close engagement with the staff, we were able to recommend actions to right-size the inpatient bed base and to help implement those actions. We worked closely with nursing and management teams to embed process rigour and highly visible data to support timely and appropriate patient placement. We were able to improve the way in which beds were managed in the trust and create a drumbeat or rhythm for the hospital. Through a process of really detailed value stream analysis, and by applying best practice and evidence-based standards and expert knowledge, we helped to redesign the ED department, introducing new models of care and new, more efficient streaming of patients. We paid a lot of attention to the assessment units. As you can see from our wiring diagram, they are very important cogs in the whole machine of ED. By using our data and analytical insights, we were able to advise on the shape and size that the assessment unit should be. Overlay this with the deep expertise we have in healthcare operations and clinical best practice, and we're able to work collaboratively with the staff to design assessment units which were safe, efficient, and provided high quality care for patients, as well as providing a well organised and efficient working environment. A key part to unlocking patient flow in the hospital is the management of the discharge process. Simple queuing theory teaches us that unless you have outflow, you will get a queue as long as there is inflow. In other words, we had to take the plug out of the overflowing bath. Specifically, we targeted pre-noon discharges from the wards, as this prevents interday congestion, which typically leads to upstream blockages in ED and critical care, which take a long time to unblock. This is one of the most change-intensive areas of the programme in my view, since it depends not only on having carefully calculated discharge targets and revamped board rounds, but a behaviour change, a cultural change at the coalface in all of the wards. The importance of flow and their role in it needed to be understood amongst all staff in all wards. This required a great deal of hands-on coaching, process standardisation, demonstration and rigour. We instigated visual management, gold, silver and bronze targets, executive walkarounds and Ward of the Week awards, all to embed new ways of working and achieve a greater percentage of pre-noon discharges. Throughout the programme, we used highly visible and highly reliable data to support the process change at all levels across the Trust. This primarily took the form of a daily ED dashboard and later in the programme, a whole system reporting suite. The whole system reports included a view of performance across both hospitals in the Trust, plus all of the schemes underway to improve system resilience in and out of the hospital. These single versions of the truth helped to feed the beast with regard to daily and weekly reporting, but also meant that less time was spent questioning the numbers and more time was spent solving the root causes and improving. So a huge amount of effort was invested, and the staff and leadership at BHRUT deserve a lot of credit for their dogged determination. The proof of the pudding, however, is whether the ED performance improved. Much of the effort during the latter part of 2014 was spent making sure that processes and the system were capable of higher performance. The right shape, size, protocols, processes, staffing, information, focus, etc. This meant that winter in 2014 was the best BHRUT had seen in many years for ED performance. And then in January to March, the final piece of the jigsaw fell into place, which was the appointment of some strong, experienced operational managers to embed the process rigour and the focus required to beat the drum. The main outcome of the programme was a significant improvement in ED performance at BHRUT, when most trusts in England were on the decline. Throughout this journey with BHRUT, a lot of successful change took place, and of course, some mistakes were made along the way. And therein lies the real learning, in my view. And we've distilled this into 7 bullet points here, the key success factors or ingredients. The first, I would say, is to engage operational staff and clinicians and patients in the change process, building trust and respect from the outset. Then, underpin operational solutions with recognised clinical standards and evidence-based best practices. Do it by the book. A system-wide problem requires a system-wide response. It's not just the acute hospital. Characterising and quantifying the components of the problem is critical. And by that I mean business intelligence, metrics, analytics, modelling. I use a term boundaryless or boundaryless thinking, and that should be applied, challenging the roadblocks to inefficient patient flow between care settings. Applying a robust improvement methodology delivered by experienced improvement practitioners is key. And of course, rigorous programme management and leadership must be applied to drive system-wide improvement. I would like to finish by paying tribute to all the staff and the leadership at BHRUT who made this programme a resounding success. They trusted us completely as their transformation partner, and we brought the expertise, the tools, and the hands-on change experience. And together, we set the bar high and stuck at it with passion and tenacity. I hope this has been a useful overview of our approach to emergency care pathway transformation. And if you would like any more information or advice, please feel free to contact me directly. Thank you very much.